Welcome again to what is the fourth and final session of our peer learning collaborative, collaborating to address the health and legal needs of patients experiencing intimate partner violence and exploitation. Today is May 26, 2022, and you are joining us for the fourth again and final session of our learning collaborative. Let's go to the next slide. As folks join, by the way, please take a moment to share your name, your organizational affiliation, and your location so we know who's able to join us today. We know on this fourth and final session, perhaps there are new people who weren't able to join the other live sessions, which is totally understandable and okay. Just let us know who you are, where you're from, and we'll model that request by, as you see Elena doing in the chat. This learning collaborative is in fact funded by the Health Resources and Services Administration, where both of us, the National Center for Medical Legal Partnership and Health Partners on IPV and Exploitation, a part of Futures Without Violence, are national training and technical assistance partners, helping health centers better address the social needs of their patient populations. Let's go to the next slide, please. Thank you. So for those of you who joined us, I'm going to skip over the bulk of what appears on the next two slides, which is more information about Health Partners on IPV and Exploitation, as well as the National Center for Medical Legal Partnership. But as I did mention, we are partnering together as national training and technical assistance partners to better address those social needs with legal underpinnings that impact, especially those patients who are experiencing IPV, exploitation, human trafficking, job and employment-based abuses. So we are embarking upon, as a group together, learning how we can really improve the health and social conditions of these patients and their communities. Let's go to the next slide. Before we launch into our conversation today, let's just remind ourselves that because we are talking about some heavy topics, domestic and sexual violence and human trafficking, which are very prevalent, unfortunately, in our communities, let's assume that there are survivors among us. So let's just be aware of our reactions and take, a moment to take care of yourself if you need to. So feel free to step away from the Zoom, turn off the camera, even mute us if you have to, right? We'll all respect that for each other, as well as confidentiality, of the clients and patients that we serve. Let me also take liberty to note that this week, yet again, we all together witnessed and experienced another act of violence, right? The sorts of things that the patients and clients we're talking about today are impacted by as well. And so please, if you need to take a moment to vent about that as well, we are here. And we'd love to hear from you, as we are NTAP partners, about what more we can do. So an evaluation link will be shared. We'd love to hear more from you about what we can continue to do to expand upon this work so that we can better address, especially what Futures Without Violence addresses, that better future without violence across the board in all contexts. Okay, let's go to the next slide. All right, so we had some learning objectives that hopefully we have been meeting. Again, there will be a survey plugged at the end, and we hope you will let us know if we effectively met these learning objectives. So number one, we're meeting to better identify strategies for building partnerships, in particular between legal services and community health centers and our DV advocacy programs. We're learning about strategies for sustaining and growing collaborative health justice responses for preventing and addressing IPV and human trafficking. And then we hopefully will have gleaned from the process at least 3 tools that can help health centers, civil legal services, and DV providers really formalize those relationships and partnerships that they have and develop or improve upon the protocols that they have for responding to DV, IPV, as well as prevention strategies. Thank you. Let's go to the next slide. All right, so here we are. We're here on session 4 with regard to partnering to address the health and legal needs of older adult survivors of abuse and exploitation. If you joined us on our opening national audience webinar, you heard from the Indiana speaker. Let's go to the next slide for the LAVA project We are happy to join her as faculty on this learning collaborative session. So we'd like to welcome Jessica Brock. She's director of the LAVA project at Indiana Legal Services. I want to avoid any further delay and pass the mic over to Jessica Brock. I also want to just note that as we've experienced since the beginning of the pandemic, sometimes there are some tech issues. And so we know that Jessica's internet access might be a little unstable today. So we'll just be patient, and you'll hear those of us who are on from the NTAP. So Elena, Camilla, we also have Dr. Kimberly Chang joining us again here today. We'll just jump in and help buy Jessica some time if her tech drops or fails her. So thanks everyone. Jessica, all yours.
Thank you. We'll hope for the best. I assume you can hear me? So far, so good?
Yes, confirmed.
Wonderful. Okay, well, so far, so good. So I appreciate the introduction, and I'm happy to be back with you today. And I'm hopeful that we can have a good conversation about how the victimization of older adults and vulnerable adults fits into the intimate partner violence conversation, and that some of our experiences might help you brainstorm ways to improve upon systems in your community to help these populations, or to create collaborations and partnerships that may not exist in your community. So if you get the next slide, please, which is a disclaimer, so we can look at it for a second and then move on. Thank you. Okay, so I just want to recap who we serve, so you have an idea of what populations I'm talking about when I am talking about domestic violence in older adult and vulnerable adult populations. So I direct a statewide legal aid project in Indiana, and we are funded by Victims of Crime Act funding, which means in part that all of our clients have to be the victim of a crime. And that crime is not always domestic violence or intimate partner violence. It oftentimes is. And as I hope we will discuss, even those clients who are not or have not experienced domestic violence or intimate partner violence, a lot of the issues that they face as a result of their victimization are similar to folks who have experienced intimate partner and domestic violence. So we represent people who are victims of crime, and then they also need to be either age 60 or older, or what we call in Indiana an endangered adult. They may be called vulnerable adults in your state. Basically, people who would be eligible for adult protective services or elder protective services in your area. So I thought, next slide, please. Thank you. I would start by outlining some of the ways that I find our clients experience similar to domestic violence and why we consider them domestic violence issues. First and foremost, as an attorney in my state, the order of protection, or maybe it's called restraining order in your area, that statute defines domestic violence for us very broadly. It includes intimate partner violence, so people who are married or in some sort of sexual relationship, that is considered domestic violence, but it also includes people who are harassed, and that's the word used in the statute, harassed, intimidated, or threatened by relatives or people they live with, and it can even be non-blood relatives. So it could be a contractor or someone working in a facility. All of that is wrapped under our domestic violence definition in our protection order statute. So as an attorney, as a matter of legal definition, all of these cases are domestic violence issues. But the other thing I would say is that a lot of the hurdles or stereotypes that victims of or survivors of intimate partner violence face or have faced historically, our elder abuse victims are facing now. For example, there's a lot of victim blaming due to ageism in the case of our older adults. You know, that grandma has dementia, she doesn't know what she's talking about, or ableism in the case of our endangered or vulnerable adults. You know, her IQ is too low to have a clue what she's talking about. a lot of our clients, when they report experiencing abuse, are not believed. And the word of the abuser is taken as gospel without any sort of follow-up. When they do call law enforcement, they're told oftentimes that it's a civil matter, that there's nothing that law enforcement could do to intervene in the violent situation. Or when a police report is made, which unfortunately in our area is not a common circumstance, the report is written from the point of view of the abuser, because again, of these issues of ableism and ageism, that the account of the victim is discounted if recorded whatsoever. So we face some of those issues. Our clients also face isolation. So whereas in intimate partner violence, we talk about grooming, for older adults and vulnerable adults, this looks like actual physical isolation, because many of them have mobility issues. So they're dependent on the abuser to get from point A to point B, either in the home itself or to appointments. So they cut off access to mail, to phone systems. Some people are literally locked in bedrooms. They can't get to the kitchen because maybe they need a walker to move about. And so they block walkways so that they're not transversible by a walker, or they refuse to take people to medical appointments. So isolation is a major problem in these cases. And then if a report is made or action is taken, again, you have those same issues of ableism and ageism appearing in the courts. It takes a lot of convincing sometimes to convince the judge that the victim should be listened to and does in fact remember what happened and know what they're talking about. So I just wanted to briefly provide sort of a link between the cases we handle and what you might more readily think of as intimate partner violence or domestic violence issues. Because to us, if they're not the same, they're very similar. So next slide, please. So I'd like to just jump into a client story just to give an example of the kind of work we do. This is an example of a vulnerable adult we provided assistance to. Her name is Kim Pike. And I'll just let Kim tell her story. And then afterwards, I'd like to walk through this with you and ask you to help me workshop how you might have addressed or would address Kim's situation in your community. So let's hear from Kim, if we may.
And tonight, ABC 57 investigates a horrifying case of abuse.
A Goshen woman wound up being locked in her home's basement by members of her own family.
ABC 57's Drew Gardner sat down with the victim for an exclusive interview, hoping to help others avoid a similar situation. Drew.
Well, Brianne, it's estimated that 1 in 9 seniors are victims of abuse, neglect, and exploitation, oftentimes at the hands of their family. In this woman's case, she invited her foster sister, her niece, and her niece's boyfriend into her home to help them out. That is where her nightmare began.
I'll just follow you down.
For close to 10 years, Kim Pike walked down these steep steps to her basement bedroom, seen here in these pictures from her civil trial. Just one window, a tiny twin bed, and a few decorations to make it feel more like home. Kim has lived in this Goshen home for a good part of her life, inheriting it from her parents when they died. When her foster sister needed a place to stay, she welcomed her and her daughter in.
I had nothing against my sister. I never have to do, but what she did to me is what I hate. And my niece.
Kim says what she did was basically terrorize her for 8 years, taking over her home, spending all her money, and trashing the place.
There's cat poop over the carpet, was sticking to the carpets. And there was paper over the floor, dirty dishes laying around. It was nasty.
They even locked her in her basement bedroom by tying a rope to the doorknob.
I was scared, but I couldn't get out. It was really tight. I had to get a pair of scissors trying to open it open so I could cut the rope to get out. But it didn't work. So I had to open my window and climb off the window.
She ran next door to call police, but no report was filed and the abuse continued, even turning physical at times.
So turned around and grabbed me by my arm real hard and pulled me downstairs so she could straighten me down, calm me down.
Eventually, Kim's home health care provider notified Adult Protective Services, and that's when attorney Jessica Brock got involved. She works for Indiana Legal Services LAVA Project. It stands for Legal Assistance for Victimized Adults.
We filed with the court to get protection orders against the mother and the daughter. We also filed with the court to have all 3 individuals evicted from the home and seeking reimbursement for damage that they did to the property.
The court granted the protective orders and the eviction and also ordered her family to pay $6,000 in damages.
And I went back upstairs and I feel very happy now and I feel safe. And I love it up here.
Now she wants others to hear her story.
And I don't want this going through somebody else but what I went through. And that's what I want to go on and do is to tell people how I feel. And I don't want this happening to somebody else, what I went through.
Now, if you or someone you know is in a situation like this, you should call Adult Protective Services or law enforcement immediately. You can also reach out to Indiana Legal Services for help. We have that information on our website right now.
Okay, thank you. So Kim was one of the first, thank you, for one of the first clients that we received from our partnerships with Adult Protective Services. They had been struggling for about 10 years to figure out a way to help Kim. And that might be a question that's discussed, why it took 10 years to figure out a way to help Kim. So I'd like to just start, and I'll trust the wisdom of others. With 16 of us, you might just be able to unmute and pipe in, or you can type in the chat, whichever. But I'd like to I mean, we know how this ends, but assume that Kim is in your community and you hear about this woman. Kim has a lower IQ. This is the home that she inherited from her parents. She's always lived in this home. It's the only sort of small world she knows. She has a motorbike that she rides to get to the store or to her mental health appointments. She and her sister, who also has a lower IQ, live together, and her sister helps her with the finances. They both manage their SSI payments. And that's kind of their little world. So you hear about Kim. She has an adopted sister who's getting a divorce and needs a place to stay with her then very small child. When this lawsuit was filed, the daughter had grown to be, I think, 24. I can't remember the age off the top of my head, but lets them in for, a few weeks. 10 years later, they're still in the house, as well as niece's boyfriend. You hear about Kim being moved to the basement, she was called a retard and all kinds of other things. You heard her talk about her wrists being grabbed to be straightened out, spending her money. Her bedroom had been taken over by these people and their cats. Anyways, so what elements, as you hear this story, would you say constitute domestic violence? Isolation, physical abuse, great. Financial abuse, verbal abuse, right? Or you might say emotional abuse. We all use all kinds of different words for that. And I don't know about you, but in our area, in a court, emotional abuse can be a tough sell. We're still working on getting courts to recognize that as harmful as physical abuse. Okay. So if Kim is in your area and you're aware of the situation, and we're going to assume you want to try to help Kim, what challenges might Kim have in accessing services in your area? What would be some things you would keep in mind in trying to help Kim access services? Or if Kim was doing it on her own, what might be some hurdles she would face in your community? There's a question in the chat. At what point does isolation become kidnapping? And honestly, I'd have to look at the statute to give you an answer to that. She's locked in the home. She can't access resources. You know, in this story, Kim reports going next door to the auto repair, the mechanic shop, and that happened more than one time. She went over there to call police and seek assistance, and reports weren't made. If you ask me why that happened, it's because Kim has a difficulty expressing herself sometimes. Do you think that that would have been an issue in your community, or do you think the police would have responded in a different way in your community?
That's without hearing the conversation, that might be a little hard to answer, but also she would go to mental health appointments. Why was there not intercession on her behalf by her therapist or caseworker or whomever she had?
I believe they're the ones that made a report to Adult Protective Services on Kim's behalf. I believe that was their intervention.
But this was going on for a long time. That's my understanding, right?
Yeah, about 10 years. Mm-hmm.
So I would mirror it to the kinds of barriers that we face in exploitation and human trafficking. You have the patient side barriers where she probably has communication difficulties, as you said. She doesn't understand necessarily that she's being victimized. You know, this is her family. She let them in, right? So she probably feels, maybe she could feel a little bit like, you know, this is I invited this up on myself. I initiated this, so it's not a problem. And then there's provider side barriers, right? Not really, you know, understanding her situation or her social context, not knowing, you know, what's going on. It took them 10 years to figure it out. So not asking the right questions.
Mm-hmm. Right? Definitely. What strengths does Kim have? Like, what, in terms of in herself or in the community, what strengths does Kim have going for her in terms of her ability to get relief once she realizes she wants this situation to stop?
Well, to compare it to my patient, she speaks English.
That's a big one. That's a big one. Yeah.
That's interesting, Kim. Can we, for especially the health center folks, or for everybody on, right? With regard to the partnerships with FQHCs, you know, there's if you are of limited English proficiency, right? Just what, Kim, can I play this out with you?
You want me to come off mute? Okay, fine.
Yeah. So it's an interesting point because of what I've already heard others share and what played out in the story. And Jessica, I don't know, do you know Kim's mental diagnosis, or if she has a speech impediment?
She was diagnosed, I might get the words wrong, with, I think they still called it MMR, mild mental retardation, or mild cognitive
impairment.
Yeah.
Impairment. I don't remember a speech impediment being listed, and she was also being treated for anxiety. And at some point, I believe she was treated for depression, but her main issue was anxiety.
Mm-hmm. And so what Kim mentioned, so we've acknowledged she has, you know, her mental health diagnosis. She's, there are, you know, those conditions result in the inability to express her thoughts, or in the most effective way to convey to the people all around her, hey, I need a legal intervention, right? Some sort of immediate legal intervention. And Kim just, you know, identified for the population, Kim, that you serve, there are non-English speaking patients, and the health centers have obligations with regard to those who are limited English proficiency to provide those translation interpretation services and support so that communications can occur. And I'm just wondering, for a patient like this, is there also, like, what would you advise, the folks in the exam rooms or at the health center to do for this patient to ensure that if they aren't yet with Jessica, what should you do to help them communicate?
For limited English proficient patients?
Mm-hmm.
Well,
where they are speaking English, but there's still a communication disability or inability.
I think this would be a hard case for me in the exam room, because I would then probably reach out to family, right? And this is the family that she's living with that's hurting her. So I think, these are complicated. It is a complicated situation.
Mm-hmm, mm-hmm.
But it sounds like in this case, Kim, the patient, the client, could express that she was not happy with the situation because she tried multiple times to leave by going through the window. So that's a resiliency factor. She had some understanding that it wasn't right.
Yeah, probably along the lines of what Margaret's noting in the chat. Mm-hmm.
Mm-hmm. Mm-hmm. And it took a long time to combat that, experience of repeatedly being discounted or not listened to, for Kim to trust that someone would believe her if she told her story one more time, and that her story was worth telling. That took a lot of coaxing to make happen.
Yeah, I think this brings to the point of the cues intervention that we often talk about, here with Futures Without Violence. For me as a healthcare provider, asking her, well, is somebody hurting you? She might say no. She might say no because she thinks that she invited, this is her family, she invited them in. But the fact of the matter is offering those resources, right? And letting her know so that that she can come to the realization, right, that she is that her story is worth sharing, would be heard, and that she can get these resources and this help. So I think that's this is a good case for that kind of intervention.
As a side note, we finally got her to court, and the anxiety was definitely a concern because she was afraid of having to face her abusers in the courtroom, that they would say things that would upset her or say things that weren't true, and what would happen if they said something that she knew was untrue. And we worked with her to have like the APS investigator she had known for those 10 years in the courtroom, and some other supports that, and we toured the courtroom before we had court, so she would know, like, you're going to sit here, and did what we could to minimize what I'm sure was a terrifying situation. But that it got off to a rough start because the judge comes in and wants to swear Kim in at the beginning of the hearing, and the judge, unaware that Kim had some cognition issues, just rattled off the oath and the instructions, and Kim didn't. She spoke too quickly for Kim, and so she's asking her to raise her right hand, to stand and raise her right hand, and Kim, like, it was sort of like a delay on Zoom. Kim couldn't compute, and by the time I'm trying to whisper to Kim what to do, it was this horrible thing where the judge looked at me like, does your client have the competence to participate in this trial? And so she made Kim sit down, and she asked Kim, who her attorney was. Like, Kim was totally not with us. And so Kim, said that I was her attorney sitting next to her. And then the judge asked her what my full first and last name was. And I thought, dear Jesus, none of my clients remember my last name. Like, we're cooked. And I don't know which angel where, but Kim produced my first and last name. And we were able to tell the judge that, she needed to give very slow, very step-by-step instructions, and Kim was able to stand and raise her right hand and get sworn in. Exactly, lawyer girl, if they even think that. So we were immediately off to a really rough start. And Kim quickly won the judge over, but that in itself could have been a major barrier, something as seemingly simple as getting sworn in. And I think the judge learned a lesson, but it could have gone in a very other direction very quickly. So I guess I'm wondering, and this is all supposition, but what do you think would have happened to Kim in your community? And another question is how you go about identifying Kims in your community.
This is Callie. I made a comment earlier, and I think a lot of times we struggle when we're providing legal services to victims of domestic violence or other abuse because they don't, and it was kind of like somebody said about human trafficking, they don't necessarily see themselves as victims, and they certainly don't present that as their first request for help. I could see the police coming to this house multiple times in my community and telling her that she needs to file an eviction. She owns the house. She should be able to file an eviction against these people and get them out. That's what the police would tell her. But then if she reached out for legal support, you know, our legal aids generally don't file evictions for people. That's not what we're not in the market of putting people out. But there are times when it is necessary to help a victim of abuse file an eviction. So most of the time, if this was a situation like ours that we identified in the healthcare or domestic violence setting, I would call legal aid directly and say, hey, I mean, we have a contract with legal aid too, but I would say this is an eviction. This is not something you typically do, but this is what the help that she needs. And we would get that going. But if she just called legal aid, the intake would have shut her down unless she said, hi, I'm a victim of 10 years of abuse by my family members, which she's not going to do. She would just call and say, I need help filing an eviction. And they would say, sorry, we don't do that.
Absolutely. Excellent point.
Callie, can I ask you a follow-up question to that? I mean, do you think that there is strategy around having built that relationship with those partners before that phone call that you might make that, you know, helps in that particular moment? Or is it that the program that you work at has been there for a while, so folks know it, so there's already sort of that trust? Well, Callie's calling, you know, this is something that needs my attention.
Yeah, I mean, I think it really is building those relationships, because once you determine what your legal partner, what their priorities are, often if you have a good relationship, you can get them to do things that are outside of their priorities in certain cases. So I definitely think having that relationship and knowing that you're only going to call when it really is an emergency, I think, and not just on every case that might be an exception to their rule.
Absolutely. This might be a good point to go to the next slide. And so in Kim's case, one way we partnered or collaborated with the healthcare partner was that her mental health professionals, you know, they made a call to APS, so got that agency brought in as an intervener, but they also kept excellent records in Kim's medical file about the reports of the abuse. And so when we went to trial, while I personally didn't work with the mental health provider, I would send sometimes Kim with homework, you know, get a note from the nurse practitioner saying, you know, that they've seen you for X period of time, or get your medical records. We had excellent documentation of the abuse in the mental health record. So that thankfully did not end up being necessary to decide the case, because Kim's testimony was so compelling, as was the testimony of the Adult Protective Services investigator. But when it comes, you know, to the he said, she said, having that record from the mental health provider was essential as another, you know, objective party documenting a history of abuse. So documentation of abuse, and I will say, in all cases of abuse, particularly in physical abuse, medical providers are probably our dream witnesses. People have lots of feelings and opinions about law enforcement and other providers. People have very few feelings other than sheer positive for EMS workers or firemen or other medical professionals. And so when they come on the stand, the credibility is off the charts because people hold them in high regard without a lot of baggage that some other witnesses may bring with them. And oftentimes they see and hear things where people have their guards down when those individuals are interacting because they're not thinking about legal consequences, they're thinking about the medical attention that's needed. And so they say and do things that they may not do in front of a law enforcement person or an attorney, and those can be recorded. And those individuals, see and smell and all kinds of things that others may not. So those reports and that documentation, I can't say enough how important all of that is. It's also oftentimes a safe place for clients to refer. In Kim's case, her mental health provider was the safe place to talk about what was happening at home. And Kim has really no filter on her mouth. I'm sure she went home and told everyone what she talked about with the mental health provider. But in other cases, there's no assumption by the abuser that when you go to your medical appointment that you're also discussing the violence that happens at home. They think you're talking about the blood pressure or the cancer or the whatever. And so it's a safe place. And while we have people who have been isolated from medical providers, people who need hearing aids or glasses who are refused those assistive devices, oftentimes even isolated individuals are taken to medical appointments. So it's a safe place for referral. And in that vein, I would say, as an attorney, I have a professional ethical obligation to kick everyone out of the room to maintain privilege and confidentiality. And I don't even, I have to. So no one has the option of inviting someone else in. And I would encourage medical personnel to kick out, never even invite back in the first place, whoever drove them to that appointment. Because if you ask the person, do you want so-and-so to come back? There's only one answer to that if they're the abuser, and that's sure, let them come back. And so that's one opportunity where they're alone and can say something. Because oftentimes the person giving them the ride is the person hurting them. So that's an opportunity to make sure things are going okay at home. And medical providers, I will also say, can be helpful when we have a victim of abuse who needs placement to safe housing or transitional services, like maybe they're moving from a facility and they're going to need community home health services. We rely on the medical providers and the care and case managers, the social workers, to help us get those interviews in place to get services, or to help us get recommendations to facilities or other care providers. So oftentimes, if not all of the time, that transitional piece is impossible without the expertise and the help of our community partners. That's just stuff we don't know how to do, for one. But next slide, please. So we've talked about Kim. Just to give a few other examples of cases where we've worked with health partners to give some other thoughts. We had a case where a gentleman is nonverbal, he has cerebral palsy, and the mother was stealing his medications and abusing him. He was participating in a PACE program, and so he would go to PACE several times a week, and he had a case care management team as part of PACE, and they were the ones who identified the abuse and helped connect the client to us for services, thankfully. But they're also the same individuals, like when we needed paperwork signed or to ask questions or to learn how best to communicate. They already had that trust and that familiarity with the client. They were able to help us facilitate those things in an easy way. That was a very helpful intervention. And he needed to move from home with his mother to a group home, and they helped us find it a safe group home and a roommate and make all of that happen. We've had some negative interactions with mental health professionals. I'm sure you're not this person. All I can say is don't be this person. But to establish a guardianship or a conservatorship, medical evidence is required to show the person's incapacity. And in Indiana, at least, and we're not alone, sadly, it can be like a 1 or 2 sentence note from a doctor saying so-and-so has dementia, period. And that's taken as like gospel. We had a case of actual kidnap. A woman was kidnapped by her daughter from Florida in Indiana, was held in the house. The daughter filed for guardianship over her, and the 2-line note saying she had dementia, we learned, came from her opioid doctor who had been prescribing her illegal opioids. So he had a customer, and it behooved his business interest to give her the note for his mom, that even though he had never met her, and mom certainly didn't have dementia. So there are unhelpful medical individuals as well. But like I said, I'm sure none of them are here. But I guess to say, if you're ever tasked with documenting a need for guardianship, I would ask you to be as thorough and thoughtful as possible when providing that assessment. And then our current sort of intervention or collaboration with healthcare partners and other community partners is a website called the Legal Risk Detector, and it's basically like WebMD for legal problems. And we're asking our community partners to run through this questionnaire with all of their clients or patients, even if a legal need isn't perceived. Just as I wouldn't know where to begin with diagnosing a medical problem. You may not know that someone has a legal problem. So by helping them go through this screening, you can identify whether someone has a legal issue, even though they may not present as having a legal issue. Any tips for trade access? That's a tricky question about immigration. So our funding sadly prevents us from representing folks who are not US citizens or lawful permanent residents unless they qualify under VAWA or some other domestic violence related visas. Yes, that's LSC funding, exactly. Basically any federal funding. I would just say that because of our confidentiality and privilege, we can't tell anyone anything if we wanted to. So we are like a vault. So even if we can't help you, nothing bad comes from contacting us because we are a vault. Like it just, what goes in does not come out. So, and I know that's hard for people to trust, but that's really all I can say is that I would lose my license if I said that you didn't talk to you, let alone what your immigration status is. And that's true for every attorney.
Mm-hmm.
Yeah.
Jessica, that question came up for me on a training call this morning for someone in the home visit services program about the reticence that individuals may have who are in need of services with regard to accessing legal services because of immigration status, in addition to everything else, right, that they're experiencing that creates that barrier. And for those who, are not the legal providers and are thinking of partnering and in these formalized partnerships, right, like MLP, you might be exchanging information about outcomes. I think it's still important to understand that as attorneys, we have to protect the confidentiality of our clients, and MLPs, along with other partnerships, do ensure that patients are aware of, especially for the patient that you were talking about, Jessica, who may have cognitive impairments and need that extra hand-holding and guidance, step by step to understand what they're consenting to as they walk through all of these different doors and gateways to services, what it is that what we still do to protect their confidentiality for everything that they're sharing with us by phone and exam rooms and offices and even legal clinics, right? Whatever setting we engage with them in that moment. So thanks.
I have a question. Oh, sorry.
No, please. No, go ahead, Margaret, please. Go ahead.
I have a question. what kind of information are lawyers legally required to share?
So it depends on your state's laws
Okay.
about what is included. So in my context, dealing with adults, under the Adult Protection Services statute, there are mandatory reporters. So in Indiana, everyone is a mandatory reporter of elder abuse, no matter who you are. However, there are exceptions, and attorneys are one of the exceptions in the context of the attorney-client relationship. That is not true in every state. So I am not legally obligated to say anything unless my client is presenting with suicidal ideation or harm to others. And even then, I'm not required to report. But on 2 occasions, we have made the decision to report that to Adult Protective Services and disclose to our client we were breaching confidentiality because we felt it was important. And obviously that results in a breakdown of the attorney-client trust relationship. But in my state, I'm not required to report, but that's different for every state in the union. It's a great question, and it's a difficult question. And that's I guess to piggyback on Bethany's point, that was the only other thing I wanted to say, and it's not a simple thing, is especially when the abuse is between a parent and child, our clients generally want it to stop, but they don't want to punish the kid. And so convincing them that, one, they get to decide if that happens in the civil context is often difficult. And 2, convincing them to even report is difficult because people have and it's a legitimate mistrust that once I call the lawyer, this is out of my hands, he's going to jail, he's going to lose his job, he's going to whatever. And trying to tell people that once you call us, like it is a vault and it's up to you what happens next. And if your decision after hearing your choices is nothing happens next, in fact, nothing will happen next. And that is a major barrier to reporting. And it's a major area of trust building to try to help people understand that we're a safe space to help identify whether you have an issue, what your options are, and then it's up to you whether or not something happens. It's a difficult thing, and I really don't know how to help people overcome that. And in our older adult population, the other piece of stigma is if I report that I was vulnerable to a scam or abuse or something, they think, and they have good reason to think this, that that's the beginning of the end, that they're going to say, oh, grandma can't handle her finances, or grandma has trust issues, or grandma blah, blah, blah. She needs a guardianship. She needs to go to the home. She needs to, and they're not silly for thinking that. That is in fact what happens most of the time. So that's another reason why these safe places to have these conversations with folks are so important, because there really are not a lot of contexts where people might feel safe to disclose these, particularly the violence with family members, to disclose those things. They don't have an outlet for that. I will say there is a resource at the American Bar Association on mandatory reporting. I don't know that I would call it user-friendly. It would be a good resource to develop. I agree with that. And so that's really what I have to share. If there's more conversation or questions, I'd love to have that. Otherwise, I'll turn it over to our hosts to discuss your resources that you have available.
Thank you so much, Jessica. That was so helpful. And Jessica also included her contact information and her phone number in the event that you want to reach out and learn more about Jessica's project and their work and in their collaborations. Go to the next slide. So at the beginning of this learning collaborative, if you think back to 4 weeks ago, we shared a little bit about our CUES approach, our CUES intervention, an evidence-based intervention using universal education in healthcare settings to provide information and resources to patients. We're going to go over it one more time and also lift up a particular resource that we have related to aging adults in the context of this conversation. Just as a reminder, CUES stands for Confidentiality, Universal Education, Empowerment, and Support. As part of the CUES intervention, we've developed a number of safety cards that are available on our website at Futures that address relationships, domestic violence, and resources available to address both in different populations. And so they've been adapted for different communities and they're available in a number of different languages. And I'm sure we'll share the link to that in the chat as well, so you can look at the resources that we have on our website. Go to the next slide. So a number of these themes have already come up and I've seen folks sort of mention them in the chat. And you know, I'm so grateful for this conversation to sort of provide some context to CUES too, and explain the ways in which it can be used in healthcare settings. You know, confidentiality, this is the idea that was mentioned before, that encouraging medical providers to see patients alone before they have conversations and use the universal education approach to giving information about healthy relationships, unhealthy relationships to their patients, and then to disclose the limits of their confidentiality to patients as well, including any limits related to mandatory reporting like we've discussed. Universal education and empowerment is about sharing that information about healthy relationships and unhealthy relationships to all patients, regardless of whether or not the patient discloses to their healthcare provider that they have had experiences of domestic violence, intimate partner violence, or exploitation. We have a bunch of sample scripts too that are available for how to facilitate this conversation using those safety cards. There's one on the slide right now. I've started giving 2 of these cards to all of my patients in case it's ever an issue for you, because relationships can change, and also for you to have the information so you can help a friend or family member if it's an issue for them. Sort of tying into this idea of altruism, of this idea that many of us, even if this isn't an issue for us right now, it might be in the future, or we might have a friend or family member who could use information about programs like Jessica's, about different domestic violence programs, about other services in the community that might be useful in the event that someone is experiencing domestic violence. And the intervention doesn't require that person to disclose, right? People have many reasons, really valid reasons for perhaps not wanting to disclose experiences of domestic violence, intimate partner violence, or exploitation, for all of the reasons that you all have lifted up in this conversation. There's also a script in the slide about making that connection using the card to the information that's in the card. The card talks about healthy and safe relationships, ones that aren't, and how they can impact your health. In situations, this is related specifically to youth, where youth are made to do things that they don't want to do, and tips so you don't feel alone. So that's just an example in the context of a conversation with youth, but I'll share in a minute our safety card related to aging adults. And then lastly, the S stands for support. On the back of the card, there are text and hotlines for folks where you can access folks who really understand complicated relationships. You can also talk to me about any health issues or questions that you may have. And then the card does have information on the back with national hotlines. You can also localize the card to your area, or even write in information to a program like Jessica's or another program in your community. You can go to the next slide. So like I mentioned, one of the safety cards that was developed several years ago by our colleagues here at Futures is called Aging with Respect. And I believe my colleague Anna already has shared it in the chat, so you can take another look at it. The Aging with Respect safety card was developed particularly to address elder abuse, neglect, and intimate partner violence with those later in life. It's developed for patients and clients in mind to provide information about healthy and safe relationships and the impact of those on our health and well-being. It includes information about financial, emotional, and physical abuse and exploitation, education and prevention strategies, and information on seeking support. And it was designed with doctors, nurses, social workers, counselors, aging services program staff, victim advocates, adult protective services staff, in mind, and can be used using this CUES approach as a way to provide universal education to all patients, regardless of whether or not they've shared that this has been an experience that they are experiencing. And I also wanted to mention that we do have other colleagues here at Futures who have done work, I saw earlier in the chat as well, working with the justice system and court collaboration specifically on the issue of elder abuse, and thinking about how to provide technical assistance to courts and community-based organizations about how to better serve older adults in the court systems. And so if you're interested in more information about those programs I saw, I'll link to it in the chat, and we can also try and connect you to some of our colleagues that work on that project as well if you have questions. I think that they've done have offered technical assistance and webinars in the past that might be useful to you as well. Go to the next slide. And so just to reiterate that this idea of universal education provides an opportunity for clients to make this connection between violence and their health problems and risk behaviors. And we strongly encourage, if you're using an IPV or human trafficking screening, to also we recommend using universal education first as part of that protocol. Go to the next slide. And the last sort of resource that I'll share too is, I've shared this a couple of times during this learning collaborative, but on our website at healthpartnersipve.org, there's a number of other resources that particularly are useful in the context of these conversations that we've been having about developing partnerships and formalizing those partnerships. So there's things in the at IPV Health Partners website about with sample MOUs to help formalize those partnerships, especially partnerships between healthcare providers and domestic violence organizations. There's also information at the website, including the sample protocol that talks about, terms, clinic policies, training requirements, this idea of universal education in CUES, resources and support services partnerships that might have been developed, scripts, reporting requirements, and documentation and coding guidelines. So feel free to also check out that resource as well. That might help you as you're thinking about how to develop these partnerships in your community. You can go to the next slide. And this is another resource that we have, which has even more information about CUES. We didn't go through all of the information that we have about CUES on this limited time that we have. Feel free to check out some of our earlier presentations, including during these learning collaboratives. We also have this information on our website, ipvhealthpartners.org, that has an online toolkit about developing partnerships specifically between healthcare providers and domestic violence programs, and more information about CUES as well. With that, I think I will pause for a minute, and this is Bethany. Do you want to share anything before I wrap up our learning collaborative?
No, we'll definitely have a follow-up email, but I do want to ask, in these learning collaboratives, folks are sharing and they realize that they themselves are also resources. And so we do have the follow-up email forthcoming with, all the links that were shared in the slide deck plus in the chat. But if you'd like to be able to connect with each other as a continued network of learners, implementers, doers, and change makers, please let us know. I think Camilla from the Futures or Health Partners and IPV and Exploitation team sends out that email. And so Camilla, I apologize in advance if people flood your inbox, but we'd love to be able to continue to foster your networking and learning. That's it.
Yeah, and just thank you everyone for joining us. And Camilla included the link in the chat to the evaluation. And we really appreciated spending this time with you over the last 4 weeks, and hope to be able to connect soon and in the future.
Thanks, everyone.
And thank you, Jessica. Thank you, Jessica.